cardiovascular S1 was when her there was no member, no value on abdomen. She had positive signs of fluid collection. On musculoskeletal, she had great sleep, bilateral kidney edema. Otherwise, same is she says specifically out of the thing she was conscious 90%, but she suddenly developed this severe side onset of short transient phase with broken blood pressure, and her oxygen requirement also increased to 50 liters, but she was not maintaining her saturation.
Initially, that will have the but this progress is sudden. Otherwise, in fact, quite steady. Everything is
The progress looks also despite the saturation level, she was stable. She was also producing urine around 300 and
what's the for incomplete tissues?
Contamination to the wall inside was concentrated and they also contacted. It was their decision to alter the doses at clinical. However, there was no need to. There was no.
We had the same when assistant AKI said we should have it. It's like a big spiral system. So we did repeat
Thank you, Dr. Sunday daytime, did you think? Questions or reported the case at ICU? No. Dates, no admissions. So last night's DTT. Any admissions reportable case? Thank you. So with this, we'll move on to today's update lecture on insulin.
Okay, thank you very much. It appears that people are interested in listening to the talk on diabetes today. So today's update lecture, as you see from the title, is Insulinization in Type 2 DM, Modalities, Evidences, Guidelines, and Patient Cases. This is a very vast topic, but I will try to take you through it. And we used to do this different talks on diabetes. This is just a disclosure and a disclaimer that every paper published on this topic is not included. See, these are my agendas. There will be an introduction and evidence and the need for insulin, rationale for use, types of insulin, novel and newer insulins, intensifying insulins. What does the guidelines say with focus on basal insulin, case series, and summary? So these are the objectives of this talk today. By the end of this session, you will be able to explain developments in the insulin from discovery to recent innovations, express importance of early intensification with basal and prandial insulin regimens in type 2 DM, describe the evidence for and types of basal and prandial insulins, distinguish approaches for the use of basal and prandial insulins in type 2 DM, and justify the need for early intensification of type 2 DM treatment with insulin. So these objectives are designed at a different hierarchical levels of learning to the level of synthesis of ideas and critiques. So as you know, diabetes is a global pandemic. in 2021, the most recently released IDF report and the IDF Diabetes Atlas. These are the numbers of diabetes worldwide. 537 million people living with diabetes this year. This is projected to rise to 643 million and to 783 million in 2030 and 2045 respectively. And this is said to be an increase of 46%. In African setting, 24 million people are living with diabetes, and this is projected to rise to 55 million individuals if no interventions are taken, and this is projected to be an increase of 134%. This is the largest of the all IDF regions. Of all these, 80% are in the low and middle income countries. Worldwide, half of those with diabetes don't know they have it, and this is 2/3 in the African setting. The leading cause of morbidity and mortality in diabetes in cardiovascular disease is the cardiovascular disease. So what about in Ethiopia? Based on IDF, the prevalence estimate is 3.3%, and age-adjusted prevalence is 5% on this most recent report. And in 2015, the STEP survey, WHO and the Ministry of Health STEP survey, diabetes is said to be 3.2%, and 9.1% of pre-diabetes prevalence is reported. Impaired glucose tolerance is very high. Death is significant, as you see, diabetes-related deaths, and type 1 diabetes also increasing, and there is a huge cost related to diabetes in terms of expenditure approaching $1 trillion USD. So top 5 countries in terms of prevalence, you see 2011 to 2021, how these countries' prevalence have progressed from low prevalences to very high prevalence. You can see Tanzania, for example, now ranking top in the list, and Zambia, Comoros, South Africa, and Seychelles, these are the top 5 countries. The increment in prevalence of diabetes is, as you see, with relation to the growth in diabetes prevalence in the sub-Saharan region. So in terms of countries, top 5 countries with number of people with diabetes, Ethiopia is ranking the 4th in sub-Saharan African setting, and this is a very alarming situation for us. So insulin discovery to recent innovations and milestones. Today's talk is about insulin in the management of type 2 diabetes. This is a picture which we commonly display, and this is a man who discovered insulin, Frederick Banting and Charles Best, who is a medical student assisting him and a biochemist. He discovered insulin in 1921, and this is the first person who received insulin in 1922. You see wasting and then increment in his body size after receiving insulin in 1922. So there are different developments, as you see from this graph, list of drugs being developed for the management of diabetes. Insulin in 1920s, then 1960s, sulfonylurea. Metformin was discovered in Europe and being used in Europe in 1960s, but in the American market from 1990 onward. After 2000, you see how the long list of drugs have been developed for the management of type 2 diabetes, and of course, in terms of insulin, also for type 1 diabetes. These are milestones in insulin development. 1921, insulin discovery, followed by protamine and protamine zinc insulin development, and NPH insulin developed in 1946, zinc insulin in 1952, following which people have been using these animal insulin products for a long period of time with their difficulties that we are going to see. Then recombinant human insulin was developed, followed by insulin pump, insulin pen development, and different insulin analogs following that was developed, and insulin lispro, detamir, and inhaled insulins, glulisine, and glargine, and nowadays different high concentration of insulin have been developed, U300 and U200 of glargine and degludec, and most recently under study is what we call once weekly insulin, insulin icodec, which is not yet approved by FDA, but there is an approval of insulin biosimilars for insulin analogs with a little bit of lower prices. So why do we talk about insulin in type 2 diabetes? There are defects in insulin secretion, action, and in delayed use. We know this is a commonly displayed slide in diabetes talks. Diabetes, type 2 diabetes is a progressive disease. When at time 0, we have almost all of our beta cells. As the disease progresses and our age increases with other risk factors, there is a reduction in the beta cell mass near to 50% by the time diabetes is developed. So this is the natural course of diabetes in type 2 diabetes progression. You see, there is a beta cell function decrement progressively. Insulin levels initially increases because of insulin resistance, then it goes down, and hepatic glucose production continues to progressively increase, and insulin resistance, once it rises, it continues to be there in type 2 diabetes. And earlier studies have shown us that type 2 diabetes is a progressive disease. In the UK PDS, in intensive and conventional therapy groups, whatever we do in terms of intervention, the disease will progress requiring insulin. You see the first year, there is a significant drop in hemoglobin A1C, and then later in both groups, the increment in hemoglobin A1C continued. So beta cell function is in a progressive decline, as it has been shown in the UK PDS. By the time of diagnosis of diabetes, almost half of the beta cell mass have already gone. So there is another concept of postprandial hyperglycemia resulting from loss of early insulin release. There is a defect in early insulin production in type 2 diabetes. So when patients are infused with or ingested glucose, there is a plasma insulin production in normal individual. As you see, there is a peak, but in type 2 diabetic, this peak is lower. And there is what was early described as our innocent bystander, which is glucagon, but not such an innocent. It is involved in the pathogenesis of hyperglycemia in type 2 diabetes. There is a decreased reduction in glucagon in type 2 diabetes, and endogenous glucose appearance is not also suppressed as it has to happen in normal individuals. And also plasma glucose increases much more in individuals with type 2 diabetes. So these are the pathophysiologic mechanisms that leads to the increment in the need for insulin in type 2 diabetes. Despite the treatments and the intervention that we put in place, we are not achieving the hemoglobin A1C targets in individuals with type 2 diabetes. The majority of patients with type 2 diabetes remain far above glycemic control. In one study in US, which also is a reflection of a global hemoglobin A1C control, there is more than 10%, above 10.1% of hemoglobin, more than 9%, 20.2%, more than 8% of HbA1c in 37.2% of patients. So 47.8% of patients with type 2 diabetes have HbA1c above 7%. Often there is a failure to advance therapy when it is required. So percentage of subjects intensifying therapy when hemoglobin A1c is above 8% is this much. In diet, those on diet, this much only. On those on sulfonylurea, 35%. On those on metformin. And these are studies which are showing that there is a lag in insulin initiation for the patient with type 2 diabetes. So whatever we do, combination therapy of oral anti-diabetic medications can fail eventually, not just even oral anti-diabetic drugs monotherapy. So in the first year, second year, third year, and fourth year, even the combination therapies progressively fail because of the pathophysiologic deterioration of beta cell reserve in the pancreas. Insulin is the most effective anti-diabetic agent. In terms of A1C reduction, even the one which is not involved with SGLT2 inhibitors, though they are really good in reducing other cardiovascular morbidity and mortality, when we compare them in A1C reduction, insulin is the best. And insulin is a more effective at HbA1c control compared to oral anti-diabetic medications. insulin has long-term benefits because, like other anti-diabetic medications, by reducing A1C by 1%, there is the benefits of microvascular complications with significant p-values in the DCCT and UKPDS studies, and also a trend toward this reduction of myocardial infarction and deaths related to diabetes. So insulin is known to be beneficial in reducing cardiovascular morbidity and mortality by decreasing hemoglobin A1C indirectly, not like the other drugs. So this is the structure of human insulin with alpha chain and beta chain correlated with disulfide bonds. Normal pancreatic function of insulin is this way. So there is a basal insulin production. Even the time we didn't eat, there is an ongoing insulin production. The time we take a meal, there is a bolus insulin production. So basal and prandial insulin concept emanates from the basic physiologic function of the pancreas. So insulinization in type 2DM goes this way. There is a basal plus, and basal bolus approaches. What are the shortfalls of animal insulin? Those were being in use in 1920 to 1940s and 60s. There is issue of impurity, antigenicity, allergic reactions were significant. A regular human insulin, it is a short acting in nature, multiple daily injections, too much physiologic release pattern, and less treatment satisfaction, and unpredictable hypoglycemia. So NPH was a drug which was devised in 1940s to 50s, and H is for the scientists who discovered and added protamine to change the pharmacokinetic and dynamic of the drug. So the name NPH, protamine is a highly basic protein. Later, zinc was added to stabilize the complex and leads to microprecipitation and delayed absorption and prolonged duration of action. And it was marketed in 1950. So these are the pharmacodynamics, kinetics profile of currently available insulins. You see insulin, inhaled insulin is the fastest actions or acting of all the insulins in the market. Aspart, lisproglulisine, followed by it is rapid action, and then regular insulin, the one which follows. So intermediate acting, long acting, and longer acting insulins are there in the market. The difference is the peak, as you see, among the human insulins and insulin analogs. There is a peak in human insulin of NPH, and the others, there is a less peak in the analogs. So the rationale for basal insulin is it suppresses hepatic glucose output and also lipolysis between meals and in night, prevented ketosis, and most individuals with type 2 diabetes will achieve adequate glycemic control with the addition of basal insulin alone. So now I promise to bring some cases to the stage, to the discussion. So this is the first patient profile. A 54-year-old male type 2 DM and hypertensive patient was on metformin, 1 gram BID, NPH insulin 22.8, amlodipine. He had his last shot last night, ran out of insulin, and could only get NPH 8 hours after his usual injection time, the next injection time. He often does not follow injection times. No recent history of hypoglycemia. A1C and FBS were 7.8% and 142 milligram per deciliter respectively, for which dose adjustment was made. He communicated his treating physician by phone for advice on what to do for his missed dose. What will be your recommendation, and what is a preferred in the ideal situation? What will be the preferred in the ideal situation? So any thoughts, residents? So he ran out of insulin. Now he's 8 hours into the last dose that he has to take. What would you advise? Would we just say, no, don't take insulin? Now he got his insulin, don't take it and just take the next dose. That is okay. Okay, we will see. So NPH is a very effective drug. There is no question about it is A1C reduction. It is useful in Down's phenomena. Down's phenomena is the time when the evening hyperglycemia results in morning hyperglycemia. So the peak will help in treating it, safe in children and pregnancy. It is relatively cheap. So it does not mimic basal insulin profile. There is this peak, variable absorption, action profile depends on dose, a risk of nocturnal and unpredictable hypoglycemia, less than 24-hour duration of action, and there is more weight gain associated with this drug. So this is the answer for the question that patient profile I posted earlier. So this is from the guidelines. If less than 6 hours, take usual dose, but be aware of potential increase in risk of hypoglycemia with next injection. If 6 to 12 hours, where our patient lies, 50% can be taken. If more than 12 hours, consider omitting dose or give 50% when remembered and 50% next dose and resume as per usual dosing administration schedule. There is additional point into this. When it is available and affordable, new long-acting basal insulin provides greater flexibility. So once daily injection, I told you this patient often misses doses. So once daily injection, no peak, there is less risk of hypoglycemia and no insulin stacking with long-acting insulin analogs. So this is a patient profile 2. A 48 years old male civil engineer with type 2 DM of 6 years duration, currently on glimepiride, metformin, atorvastatin in those doses. He came for routine 6 months follow-up, worried about his physical appearance at work. His blood pressure is 120/80, weight is 58, BMI is 19, abdominal circumference is 86. Recent 5 days self-monitored blood glucose has values of fasting blood sugar of 140 to 200 and 2-hour postprandial blood glucose values of 150 to 210. Fasting blood sugar is 182, A1C is 8.9, creatinine is normal, complete blood count, livers, lipids are within acceptable ranges. So the best choice to optimize his glycemic control is A, B, C, D, E. So we used to say just 4, but I mentioned 5 here, it's okay. So what do you choose? Glimepiride is 6, metformin is 1 gram, and atorvastatin. A, B, C, D, E. Hannibal? Huh?
I'll probably go with D.
With D.
Might give us better glycemic control. The patient also might have the variant benefits from the SGLT inhibitors.
Okay. Any different opinion? Malaku?
I would start balance because the goal, the A1C is too far from the goal to be corrected by a single parameter.
Okay, so we will see. So let us go to the basal. Ideal basal insulin. This mimics normal pancreatic basal insulin secretion, the ideal one. The flat pattern that you have seen in the earlier picture, a long-lasting effect around 24 hours, a smooth, peakless profile, reproducible and predictable effects, and it is reduced risk of nocturnal hypoglycemia and weight gain, and once daily administration for convenience, and it has to give us flexible meal timing. So these are the good characteristics of ideal basal insulin. So I will take you through some of the available basal insulins. We know we have commonly NPH insulin in the market in our public places, but these are not the only drugs. We have insulin analogs in the market. So I will take you through this. So insulin glargine was marketed in 2000. So it is not a very new drug. It has been there for more than 20 years in the market. So it is developed by modification to human insulin chain by substitution of glycine at position A21, addition of 2 arginine at position B30. You see there are 2 arginines added here. So there is a gradual release pattern from injection site, peakless, long-lasting insulin profile. So this is how it appears. It is a chlorine solution with acidic pH. And when it is injected into subcutaneous tissue, there is hexamers dissolution into dimers and the monomers, which goes into the circulation and slow dissolution of free glargine hexamers from precipitated glargine. That is why it has a protracted action. So once daily insulin glargine has consistently demonstrated efficacy in helping type 2 DM patients achieve target glycemic control. So there is a consistent achievement of HbA1c targets or close to it with glargine when glargine was added to type 2 patients uncontrolled on oral antidiabetic drugs. This is called Basel oral treatment regimen. So these are different studies which have showed A1C improvement. What is the other good side of insulin glargine? There is, in comparison to NPH, based on the pharmacokinetics that I have showed earlier, and this is from a clinical study, symptomatic hypoglycemic effects are much lower with insulin glargine with a very significant p-value. Limitations, it cannot be mixed with other short rapid-acting insulin. The pH of the formulation is acidic. Initially, it may produce burning sensation due to acidic pH. So meta-analysis of all the trials in terms of nocturnal hypoglycemia, when glargine is compared to NPH, there is a significant reduction. When detamir is versus NPH, there is a reduction, and degludec versus glargine, there is a reduction in nocturnal hypoglycemia. I will highlight about detamir and degludec. So there is one important study that have looked into cardiovascular safety outcome in insulin, the origin trial. Among the insulins, this is the one which have been seen into cardiovascular outcome study. So this is a large international RCT, patients with new or recently diagnosed DM, impaired fasting glucose, IGT, and additional CV risk factors. This is the longest investigation, the effect of insulin treatment on CV outcomes and cancer incidence in this population, follow-up for 6 years. So there is one objective is to see relationship between long-term fatty N3 omega-3 fatty acid supplementation and the rate of CV event, and the other co-primary outcome is effect of insulin glargine on CV outcomes. These are the baseline characteristics and the large sample size. You see 12,573 sites and glargine versus standard treatment with also omega-3 fatty acid versus placebo. As expected, there is a significant reduction in fasting, median fasting blood glucose, because this is insulin, it is doing its job. But in terms of primary outcomes, MACE, myocardial infarction, stroke, death from cardiovascular causes, co-primary outcomes, it is non-inferior to the standard treatment. And the other co-primary outcome of revascularization or hospitalization for congestive heart failure, it is also non-inferior. And death from any cause, it is also non-inferior, but it is not superior. It didn't reduce the deaths like the other anti-diabetic medication. So this is the Frost plot. You see the line is close to 1, so it has proven non-inferiority, but there is no superiority. As expected, there is an increase in hypoglycemia because this is insulin in comparison to the other oral anti-diabetic medication. So the implication from origin for insulin therapy is compared with standard therapy in patients with type 2 DM, IGT, or IFG, using once daily basal insulin glargine to target fasting plasma glucose of less than 95 for a median 6.2 years, maintains near normal glycemic control, neutral effect on CV outcomes and cancer, slow progression of dysglycemia, modestly increase hypoglycemia, and modestly increases weight. Implication for insulin therapy. Supplementing endogenous insulin with basal insulin slows dysglycemia progression. This is proven from other practices as well. Although later benefits or harms cannot be ruled out, over 6 to 7 years, exogenous basal insulin flexibly lowers glucose. Despite lower glucose levels, routine early use of basal insulin glargine is not better than guideline-based standard care in limiting important health outcomes. So we need to follow the guidelines Basal insulin glargine currently the best studied glucose lower drug available. No new safety outcomes, limits, early use when it is needed. So we can use it early when we need it. So the answer to the case profile 2 is increasing, I said, increasing glimepiride to 8 milligram. That we often do from 6 to 8. It's not going to result in any good glycemic control. Once we pass 50% of the maximal dose, the benefit we are going to gain is much limited. Achieving glycemic targets, as in this patient, we need to have a good body weight. This is an engineer. His BMI is 19, very slim, and he wants us to put some body weight and appearance. So better physical fitness is required. Insulin is of choice. Guideline recommend starting with basal insulin, then titration of basal insulin, then intensification to basal plus and basal bolus. In a patient with significant concern of body weight loss, both SGLT2 inhibitors and GLP-1 agonists are not good choices. So you need to individualize care. It's not only the fact that drugs are beneficial, we need to individualize care. The patient was started on glargine 10 units a day and progressively titrated. So the other basal insulin that is there out is insulin detamir. And this is not also new, it is available locally. Both glargine and detamir are available in our markets, in private setting at least, and we are also using them. So this is a molecule to which a side chain fatty acid of mesteric acid is added, and this resulted in the change in the property, neutral pH, longest extended action, more within patient consistency, and less hypoglycemia and less weight gain. So from meta-analysis of randomized trials, detamir versus NPH, in terms of hypoglycemia, nocturnal hypoglycemia, both in type 2 and type 1 DM, there is a significant reduction, and severe hypoglycemia, at least in type 2, type 1 DM patient, there is a reduction, but from other studies also, there is a reduction in nocturnal severe hypoglycemia with detamir. So insulin detamir versus insulin glargine for type 2 DM, which one to choose? These are in the systematic review, there is no clinically relevant difference in efficacy or safety between insulin detamir and insulin glargine for targeting hyperglycemia. In terms of A1C reduction, they are comparable. However, to achieve the same glycemic control, insulin detamir was often injected twice daily in higher doses, but with less weight gain, while insulin glargine was injected once daily with somewhat fewer injection site reactions. So basal insulin characteristics, these are the NPH, the basal insulin, the earlier one. There is what we call in the analogs, first generation, second generation insulin analogs. Now third generation are being processed in the market. The first generations are detamir and glargine. You see glargine 24 hours and detamir 20 hours duration of action. Degludec 42 hours. Glargine 300, more than 24 hours. And peglispro, basal insulin pegylated lispro. This is where a good idea of trying to mimic a physiologic function of pancreatic insulin production has resulted in a bad outcome, and this is abandoned because of increased hepatitis and dyslipidemia. They tried to direct insulin to the liver by attaching by pegylation of insulin lispro, but it didn't work out. So in terms of efficacy, insulin glargine, insulin detamir, and NPH, in glycemic control, there is no difference. In efficacy and safety, hypoglycemia is much more with NPH, weight gain is much more with NPH, as you see it is neutral with detamir, and long-term efficacy are comparable, and detamir is more expensive than even glargine. So insulin degludec, this is Tresiba, a long-acting insulin analog. By addition to the basic molecule, 2 fatty acid chains and addition of other molecules to the side chain. This is how it works. The moment we inject, insulin deglutic dihexamers after injection are formed, phenol diffuses out, insulin deglutic multihexamers are created. When zinc diffuses out, insulin deglutic dimers change into monomers, then it exerts its action. These characteristics gives it a retarded absorption and a slower action and prolonged action. It gives, I said, basal insulin, a good one, should give us a flexibility of dosing. This insulin deglutic, because of it is a slow absorption and a slower action, it gives us a flexibility in dosing. So it can be given one Monday morning, for example, then Tuesday evening, a 40 hours difference because of it is prolonged action. Then it can be repeated after 8 hours, again after 40 hours. So it gives flexibility in dosing and meal intake. So this is a patient profile 3, a third patient. This is 58 years old female patient with 20-year history of type 2 DM. On basal bolus insulin with glargine at bedtime and pre-meal lispro insulin, metformin 1 gram BID, dapagliflozin, asks if one of the newer long-acting insulins will improve her glycemic control. She has been adherent and adjusts her insulin lispro with meals, maintained relatively tight glycemic control with stable, mild background retinopathy, takes always lispro bolus before meals, adjusts prandial insulin, and closely assesses carbohydrate contents. So this is a type 2 diabetes patient who is using insulin meters. The previous updated lecture by Dr. Tadla, even type 2 diabetic patients can use continuous glucose monitoring. The downloaded results showed that there is a pre-meal glucose 138, post-meal glucose average 168 with moderate glucose variability, 8% reading are below 8 milligram per deciliter, A1C 7.5, no other lab abnormality. So switching her regimen from insulin glargine to insulin degludec would be expected to result in reducing post-meal glucose, hemoglobin A1C, nocturnal hypoglycemia, frequency of injection, and microvascular complications. Any thought from residents? D, no? Frequency of injection. Hello. So this is a study on insulin degludec. A switch trial is, as it appears from the name, this is a study designed to switch patients from insulin degludec to insulin glargine and the vice versa. This is the study design. In type 2 patient is switch to, in type 1 individual is switch 1 trial. So this is a very good design, and I will go to the findings. Non-inferiority in terms of HbA1c over time, there is no inferiority. It is comparable to glargine in A1c reduction. That is insulin degludec comparing to insulin glargine. And in terms of reduction in symptomatic hypoglycemia in the maintenance phase, type 2 diabetes patients has lower hypoglycemia, 30% lower with insulin degludec, but type 1 lower hypoglycemia, but still it is lower in type 1s as well. Symptomatic nocturnal hypoglycemia is much more lower in type 2 diabetic patients, 42% lower with insulin degludec. So there is issue of what we call glycemic variability. The glycemic variability is when we compare degludec to glargine. In degludec it is much lower. In glargine, detamir and NPH, detamir has much lower glycemic variability when it is compared to glargine and NPH. So insulin degludec is ultra long acting insulin analog with duration of action of more than 42%. Flat, stable glucose lowering profile with lower within patient day-to-day variability compared to insulin glargine. And it provides similar glycemic control to insulin glargine and allows for the flexibility of injection time without compromising efficacy or safety, and reduces risks of nocturnal hypoglycemia versus insulin glargine with the potential for tighter glycemic control, and it can be formulated with aspartame. So the answer for the patient case I posted earlier is A1C 7.5. Modest increase in risk of macrovascular complication. The goal of treatment is to lower A1C cautiously because of frequent hypoglycemia and to decrease frequency and severity of hypoglycemia by increasing glycemic target if hypoglycemia and awareness, more physiologic insulins like insulin pump, accurate adjustment of prandial and basal insulin using newer insulins. So due to less variable plasma concentration, insulin degludec and U300 insulin glargine are associated with less nocturnal hypoglycemia. So the answer is less hypoglycemia. In terms of hypoglycemia, insulin degludec is better than insulin glargine. There is no difference in A1C reduction, post-meal glucose improvement, frequency of injection by standard recommendation, and no studies of difference for microvascular complication. So in terms of switching, a very practical question between different formulations of insulins, especially when we switch from one formulation to another formulation, we need to reduce the dose at least to 80%. That is the take message. And when we change from mixed start to analogs mix, 1-to-1 can be used. So when in whom to initiate insulin? When there is a maximally tolerated non-insulin agent, but A1C above the target, new diagnosis of A1C above 9, some recommends above 8.5, when there is metabolic decompensation, significant weight loss, polysymptoms, when there is organ failure, patient with previous or current gestational diabetes, acute illness, prolonged course of steroids, intolerance to oral medications, anytime the physician considers it is appropriate. So when not to initiate basal insulin, there is no contraindication as such, but somebody who cannot inject, elderly, there is no one caring for him, we may avoid insulin administration because the risk of hypoglycemia is much worse than whatever we want to achieve. So intensifying to injectable therapy according to ADA 2020, and the same is also there in 2021 guideline. When A1C is not in target, consideration of injectable treatment is important. So either basal insulin or addition of GLP-1 receptor agonist as basal insulin, followed by addition when A1C is not in target, addition of basal plus addition of prandial insulin to the largest meal of the day, following A1C and glycemic target achievement, addition of basal bolus regimen is the recommendation. So another patient profile, a 64 years old insurance company covered female pharmacist, has type 2 DM, 10 years, hypertension 6 years, and ischemic heart disease 4 years duration, metformin 1 gram, dapagliflozin 10 milligram, atorvastatin 40, aspirin, telmisartan, and insulin glargine 55 units knocked. She has came concerned about central adiposity that is not decreasing. Despite some of her efforts, she reported that her sister has undergone surgery for medullary thyroid CA. Physical examination, blood pressure is okay, weight is 72, BMI is 22, abdominal circumference is 102, and her lab showed A1C of 7.6, fasting blood sugar is 119, creatinine is 1.32, others are unremarkable ECG and echo are not remarkable, and her SMBG showed this. These are the values on self-monitored blood glucose. So the best glycemic control optimization for this patient will happen through what? A is meglitinide addition before breakfast, B liraglutide addition to basal insulin and OS, oral antihyperglycemics, DPP4 inhibitor addition to basal insulin and OS, decrease basal insulin and add rapid acting insulin analog to basal insulin and oral antidiabetics. So you can go through these numbers: fasting blood sugar, 2 hours of breakfast, before 2 hours of lunch, and 2 hours of dinner. You will consider D. Okay. So the concept of basal plus therapy. This considers the addition of increasing injection of prandial insulin, beginning with the meal that has the major impact on postprandial glucose values, and maintaining previous treatment with basal insulin and oral agents represents an effective strategy for a soft transition to the more physiologic and effective replacement of insulin by means of classical basal bolus therapy. So this is, as you see on this case, you see here, the numbers are very high. This is not in target. A meglitinide addition before breakfast. If you add meglitinide, which is a prandial sulfonyl insulin secretagogue, we are going to push the patient into hypoglycemia rather than improving or doing anything good. Liraglutide and DPP4 inhibitors should not be given to this patient because there is a strong family history of medullary thyroid CA, which is a contraindication to use these medications. So decreasing basal insulin. Why do we decrease? 67, 70, this is hypoglycemia, maybe at night. So we need to go down basal insulin and add prandial insulin at this time to basal insulin and oral anti-diabetic medication. So this is the summary of the concept. Lifestyle change plus metformin, basal insulin and titration, basal plus, and prandial insulin at main meal, and then it goes to the basal bolus. Or the other way, somebody can consider adding DPP4 inhibitor, GLP-1 analog when basal insulin is started, and SGLT2 inhibitor can be considered as well. So basal bolus is proven to be effective from different studies. This is just one example that I am quoting here, a proof of concept study for insulin glulisin addition to insulin glargine. So it is proven to be effective. So whenever we treat a patient with diabetes, we need to consider this. That is why you see hemoglobin A1C and fasting blood sugar have been reported in different cases that I have showed you. So we need to address both postprandial and fasting blood glucose to have achieved a good hemoglobin A1C. So the link between postprandial hyperglycemia and CVD, there are evidences from epidemiologic data and pathophysiologic hypotheses, randomized prospective intervention trials that postprandial hyperglycemia may be related to CVD, but randomized controlled trials did not show postprandial hyperglycemia to be strongly related to it, but surveys like DECODE study, which is a prospective observational study, have showed postprandial hyperglycemia is associated with mortality. So RCTs, as I said, did not show a strong correlation. And the effect of post-meal hyperglycemia, there is increased risk of microvascular complication, a risk of cancer, impaired cognitive function in elderly people with type 2 diabetes, and treatment with agents that target post-meal plasma glucose reduces vascular events in pre-diabetes. As I said, RCTs did not show that. So selection of an appropriate candidate for insulin intensification with basal plus therapy. So those who are not in target despite oral agent and basal insulin, patient treated with 2 or 3 oral agents and a high A1C above 8.5, basal insulin oral agent with an A1C above 8 who are reluctant to start basal bolus therapy. You need to go through these ways. These are the ideal candidate, the first group. And the second group is after optimization of titration of basal insulin. And the third group, basal plus, should be considered as a transitional therapy to progress steeply to basal bolus therapy. So there are different ideal candidates to the basal plus and basal bolus therapy. Starting prandial insulin dose and adjustment algorithms, there are different ways, but the initial way is we can go it either with fixed dose or based on the blood glucose or based on the weight, 0.05 unit per kg or 4 units at the largest meal of the day. Then adjustment can be made by adding 1 or 2 or 3 units based on the blood glucose values. So this is just look into this self-monitored blood glucose profiles. 64-year-old non-type 2 DM patient for 16 years, Mixtar 3070, insulin 4822, metformin, and rosuvastatin. SMBG has been seen by her GP with trial to modify her insulin dosing to no avail. She has symptomatic nocturnal and afternoon hypoglycemia. The blood pressure, weight, and BMI are okay. Abdominal circumference is 94. Hemoglobin A1C is 9.8. But fasting blood sugar is 118. And creatinine is 1.2 milligram per deciliter. This is the self-monitor blood glucose. Fasting, 2 hours of breakfast before dinner and 2 hours of dinner. So what is the best strategy to avoid this glycemic variability in this patient? We see here fasting 95, 72, 56, 78, hypos. After breakfast, hypers. Before dinner, it seems okay. 2 hours of dinner, it is still very high. So what should we do better? Mixtar, the GPU ከፍ ዝቅ ማድረግ ሞከረ ሲጨምረው ይወርድበታል ወይ ይጨምርበታል, and it didn't work. He sent her to the residents and to the internists and endocrinologists to adjust this insulin treatment for this patient. So this is mixed-tard insulin. This is the downside of the mixed-tard insulin. The patient has nocturnal, morning, and afternoon hypoglycemia with severe postprandial hyperglycemia. When affordable, basal insulin analog with rapid-acting insulin analog is preferred over pre-mixed regimen of NPH and regular insulin in this patient. Because hypoglycemia is deleterious, you cannot do this. You need to give a drug that decreases risk of hypoglycemia and also at the same time controls and allows you flexibility in titration. So basal bolus insulin regimen is the better choice of insulin therapy in this patient. Patient doing calcium, we have to go for mixed split regimen. ለብቻ አድርገን NPH-ንም regular insulinum titrate ማድረግ አለብን. So few words on biphasic insulin aspart. This is insulin analog that has a biphasic approach like a mixed-tard 30-70, no? And the quality of this one is it is the qualities of insulin analog with no that pronounced peak over the NPH insulin component. So it has faster absorption, higher peak concentration, more rapid and pronounced glucose lowering effect, similar duration of action of the basal insulin component. So studies have shown there is the lower rate of major hypoglycemia when compared to mixed carb insulin. And also nocturnal hypoglycemia is lower with biphasic insulin analog when we change from premix insulin to biasp or biphasic insulin lispro as well. We change it in a 1-to-1 ratio. The last case in this discussion is this one, type 2 diabetic patient, 61 years old, hypertension, hypertensive heart disease, CKD, and bilateral visual loss because of diabetic retinopathy. He has been to USA in a family visit. He's on glargine 46, lispro 6 p.m., metformin 1 gram BID, amlodipine 10, lisinopril 20, furosemide 40, atorvastatin 80. He has no episode of hypoglycemia since his last visit. These are the blood pressure, abdominal circumference, and insulin injection sites are free. A1C is 7.8, and the labs are okay, and urine analysis protein is +1. How do you optimize his glycemic control? Fellows, maybe you can take up this. Okay. So this is this profile. So this is a patient on a Basal plus. Now, based on this data, hemoglobin A1C is there and the blood glucose after breakfast is consistently high. So the one simple answer to this is to go to Basal bolus BID, Basal once. But the other, this is the reality in life. We may go down with the insulins and then consider SGLT2 inhibitor in this patient. Yes, CKD, hypertension, a lot of this. So finally, we are talking about blood glucose in these patients, but don't only be glucose-centric. Focus on everything in the patient with type 2 diabetes to accrue the benefit. So as Steno to multifactorial treatment approach to reducing CV events and mortality have shown a significant benefit, a reduction in mortality. As you see, the curves are separating from the beginning. And also in Frost plot, there is a significant benefit in nephropathy, retinopathy, autonomic neuropathy, the microvascular complication components by addressing multifactorial risk reduction. And the mortality is reduced by addressing multifactorial and intensifying oral antihyperglycemic agents alone early on. It may improve the blood glucose, but it does not decrease the cardiovascular mortality by metformin and sulfonylurea. This did not include the currently available medications of SGLT2 inhibitors. So in summary, basal insulin should be considered when glycemic targets are not met with oral antihyperglycemic agent in type 2 DM. Basal insulin should be closely titrated to achieve glycemic target while avoiding hypoglycemia when available and affordable. First and second generation basal insulin analogs provide stable plasma concentration, minimizing overall and nocturnal hypoglycemia risks in both type 1 and type 2 DM patients compared to NPH. Mealtime insulin should be considered as basal plus and then optimization to basal bolus as needed when glycemic targets are not being met with basal insulin alone. So thank you. These are some of the references I used for this preparation. So question, comments? We are almost on time, some 5 minutes. Yes, Dr. Lisa.
Really nice to be management. I'm happy also with the kids that you give. It's a really clinical challenge. My question is, first newly diagnosed type 2 diabetes, they had learned to switch from oral to insulin. The challenge. What's happening with insulin? What's your experience from the very beginning? Passing is wondering about HbA1c is like as you said 9 or so. We think that insulin is more beneficial, but what's your experience in terms of convincing them getting them to insulin from the very outset?
Thank you, Dr. Lissan, for raising a very practical issue. We know from clinical and evidences that we know addressing glucose toxicity and lipotoxicity is a very important thing in treating individuals who are newly diagnosed with diabetes and even who come with hyperglycemia later on. At any time when we intervene with appropriate intervention, reducing of glucose toxicity and lipotoxicity will benefit the patient in the longer term, and it may keep them away for a while from the injections. So it is not easy to convince a patient, but it takes a lot of effort and giving some time explaining for the patient these benefits. From my personal limited experience, when you give them more time to understand it, to have it in-depth understanding of the benefit, usually our patients do accept. But for the majority, patients are afraid of injection, and there is a lot of misbeliefs and misconceptions about insulin. People tend to believe whenever they get insulin, they may get even worse than the situation they have been into. But accepting insulin, there is insulin needle phobia, but patient does not have that fear from other forms of diabetes treatment, injectable forms, even like liraglutide, for example, GLP-1 receptor agonists. That degree of fear and phobia has not been reported. It is only for insulin because of the relation with different misconceptions and belief, but some more effort, more time, more explanation has to be given for the patients. Yeah.
Thank you, Dr. Abdul. An excellent talk on insulin specifically, many. And we spent time to that this one in the previous talk. We say it's just a covalent category. Because the mortality due to type 2 diabetes mellitus is mainly basically cardiovascular complication. And these insulin analogs, in which you have presented to us is basically for ideal patients. Most of your cases are ideal patients. Fasting blood sugar after breakfast, after lunch, after dinner, checkups, and then which one to choose. Body weight, which one to choose. Hemoglobin A1C high, which one to choose. Yes, it's okay. Still, we have to have ideal patient. But taking into consideration the price of these insulin analogs and the mortality, which is a cardiovascular effect of these insulin analogs, like comparing with SGLT2 inhibitors, what was your recommendations, and how do you see the hemoglobin A1C report in our setup to decide again the second question?
Okay, thank you very much, Dr. Ufera. You raised a very important question. So this is an update lecture that we have to show also what is there out, even though they are expensive, the availability is limited, but we are seeing these products in our market. If we see into insulin analogs availability, we have one rapidly acting insulin in our market. Insulin Lispro is available in Addis Ababa. Glargine is available. Detamir is available. And Degludec is in the process to come to our market. Having said that, I agree with you and concur to the idea that these drugs are really expensive, no doubt. But even despite the benefits of SGLT2 inhibitors in cardiovascular mortality and morbidity that are now being given a clearance to be even used in non-diabetics with increased cardiovascular mortality, bringing down hemoglobin A1C still remains a very important factor in managing type 2 diabetes individuals. So when A1C, despite using other oral anti-glycemic agents, SGLT2, DP4 inhibitors, metformin, or even sulfonylureas at times for drugs, which we rarely practice, is not brought down under control, we need to consider insulin. Of insulin, if the cost is an issue, that is what the guideline says, even for insulin. If the cost is an issue, we go for human insulin, which is relatively cheaper. But if there are some other issues of weight gain or severe hypoglycemia and the patient can afford, still insulin analogs are good. We can talk about these drugs only when the issue of cost is not an issue. Otherwise, it is the human insulin which is there. In terms of A1C reduction, to be honest, based on the reviews and the guideline recommendations, A1C reduction, these analogs are not superior to human insulin. They are comparable in A1C reduction or glycemic control. But the other benefits of weight gain or severe hypoglycemia puts them at advantage. Again, when somebody has money, the comfort with using insulin pens, allows the patient to use these drugs. Your other question?
How this is a standard of hemoglobin A1C?
Hemoglobin A1C. Hemoglobin A1C is being reported everywhere, here and there, from different labs, but we really advise to get it from good lab, because the commercial assays, which are not standardized to ADA and DCCT guideline standard protocols, are not advised to be taken to make a clinical decision. Hemoglobin A1C should not be taken alone to make a clinical decision again. That is why I showed you the pyramid. Sometimes we see fasting blood glucose is okay, and hemoglobin A1C is high. So you need to go a bit further, do some 2 or 3 days monitoring. If this hemoglobin A1C is really what the patient is going through now, if you make a decision based on hemoglobin A1C alone, hemoglobin A1C is a history, not a very recent report. So you have to compare it with that one to make a good judgment to avoid hypoglycemia, especially in those with comorbidities.
You are right. Most of our labs, they don't do standardization for the results they got for hemoglobin. You have to keep in mind.
That's important. Yeah. But the good labs are really good. We can depend on them. Yeah. Yes, Dr. Malaku.
Thank you. This is the time presentation for 2020. We are celebrating the 100th year of insulin therapy. The other this Saturday, I have heard that Ethiopia has received more than 30,000 doses of insulin analogous intermittent from donation from US. It's going to be probably a public hospital solution. We should a good update. My question is, even biosimilar generic insulins were included in that donation. Are you sure about their efficacy?
Thank you very much, Dr. Malaku. So this is a very good point. I said we remember donating some insulin through the association to a public places, like insulin called Basal. It is a biosimilar insulin glargine. So knowing these drugs is very important. As you say, now these drugs are coming, and that donation will go to a public place, not to a private place. So knowing them is very important. The biosimilars have got FDA approval. One is Basal in 2020, and now recently this year, there is another biosimilar insulin glargine which is approved. So the safety is okay, and the cost is cheaper. That is the benefits of biosimilar. Okay, so thank you very much.
Bami, dinner. How's it going? Hey, dinner. Salam. Thank you. I don't have your email. These two? Thank you. Makale ya British. Let's check how it works. Cairo.
እባክህን ዛሬ